This is Where We Live on Connecticut Public Radio. I'm Lucy Nalpathanchil, broadcasting remotely. You've heard about vaccine passports. They could play a part in the vacation you've been dreaming about taking during this last year. How would they work, and who would they disadvantage the most? Coming up, we hear from a global health management researcher from the University of Central Florida, and we want to hear from you too. Documents proving COVID-19 vaccinations could help prevent further lockdowns, but how would they affect our perceptions of risk, especially as more contagious variants of the virus persist? That conversation coming up. First, Connecticut may be among the leading states in vaccinating its residents, but right now the number of COVID cases have not been declining. For more perspective on Connecticut's situation right now, joining us on Zoom is Dr. Saad Omer. He's director of the Yale Institute for Global Health. Saad, welcome to the show.
Thank you. It's my pleasure to be here.
Now, I understand you just got off a call with the World Health Organization this morning. You were on the WHO's working group on COVID-19 vaccines. Just this week, we've heard Germany heading into a third lockdown. Meanwhile, the U.S. is vaccinating Americans faster than other parts of the world. But when you look at this pandemic, where we are today, what concerns you the most?
Well, what concerns me the most is the new variants spreading in various parts of the world. But I don't think it's a cause for unnecessary concern. So we should be concerned about these variants. We should take action to preempt these impacts of these various variants that are out there. But we should also recognize that we have the tools to address them. The other thing that concerns me is a premature relaxing of interventions, not the most strict ones, but even the ones that are not as intrusive as some of the other ones, and then seeing a surge that may come our way.
So let's talk about restrictions. Obviously, in Connecticut, wearing a mask is still something that people are told they must do, but the governor has relaxed capacity for businesses and gatherings. How do you feel about that?
So I have a sympathetic perspective on this, and I understand that businesses are suffering, and there is a substantial impact of restrictions on capacity, etc. On people's livelihoods. On the other hand, I think in terms of the epidemiology of this virus in our state, I think would have been better to wait for a few more weeks as we increase our vaccination rates further. So remember, it's one thing to say that we are better than others. It's another thing to have good enough rates to relax some of these restrictions. So I don't think anyone is seriously advocating for full-on lockdowns and that kind of stuff in our state. But some of the things that were in place in terms of reduction of capacity or restriction on capacity for indoor gatherings, such as restaurants, etc., and bars, and so on and so forth, those kinds of things have an implication on our disease rates and then, unfortunately, on our mortality. The good thing is that in our state and throughout the country, the very initial stages, after that it changed, it diverged, but the very initial stages focused on the highest risk groups, i.e. the elderly. So there is likely to be an impact on protecting the most vulnerable, even at this stage, even with this relaxing of restrictions, but there will be a cost, unfortunately, of acting a little bit too early.
So I'm glad you're talking about metrics, Saad. The New York Times COVID tracker has Connecticut in the area of states where cases are high and staying high, where when we think of high, 15 or more cases per 100,000 over the last week. Connecticut is around 26 per 100,000. And so is that something that people should be paying attention to?
Yeah, exactly. So look, vaccination rates are a reasonable, good metric for our efforts. But at the end of the day, we are not aiming to score high in a New York Times scorecard. Our focus should be to reduce death and hospitalization and disease, and keep it low on a sustainable basis. And so while, again, this kind of, the talking points on this kind of a horse race with other states is, I can understand at some level, but our focus should be, reducing death and disease. And so I think we should continue to pay attention to case rates, but also mortality rates, etc. And because there is, even now, in a situation where things were trending very significantly in a very significantly positive direction for several weeks, and then after that there has been a plateau, the absolute rates of cases and deaths remain reasonably high.
Mm-hmm. Again, you're hearing Dr. Saad Omer. He's director of the Yale Institute for Global Health, as we start by talking about the situation Connecticut is in a year into this pandemic. If you have a question, you can join us, 888-720-9677, or find us on Facebook and Twitter at Where We Live. Let's talk about Connecticut's vaccine rollout. Again, the governor's administration deviated from CDC recommendations for rollout by thinking about this strictly by age, with the exception of teachers. So what's your take on that approach, Saad?
I think there was a lot of value in focusing on age in very early stages and some of the highest risk groups, and even going down to, let's say, 55 or above, because we know that the risk of death is really, really high as your age progresses. Just to be clear, everyone at all ages is at an elevated risk of death and hospitalization due to this pandemic, because it was a virus that none of our immune systems had seen before it emerged. But relatively speaking, older individuals are at a higher risk and a substantially higher risk. But then there is also an equity angle. So if you related to where you draw the line. So if you draw the line at 75 or above, you capture more than 70% of white deaths nationally, whereas only 44% of deaths among African Americans and Blacks, etc. And so therefore, having a too high a cutoff had equity implications as well. So going down to 65 and then 55 had other implications as well, in terms of not just reducing mortality, or impacting mortality and severe disease, but also on doing so equitably. But beyond that, I would say having a completely age-based strategy and then opening up to everyone had implications for those another group, especially under 55, between 18 and 55, or 16, because Pfizer vaccine is approved for 16 and older as well. But, in that age group, there's a huge chunk of people that have high comorbidities. And what happens is, when you open it up for everyone, technically everyone is eligible, but then you are not in line. You're in line with everyone else. And what does it matter now that, one could ask, what would happen, if we open up to everyone, and that we are approaching that stage very quickly? What happens is that even in an expanded supply scenario, we are in a situation where the probability of someone with a comorbidity getting, people with, diabetes plus heart disease, or some of the other comorbidities that are in that high-risk group, kidney disease and so on and so forth, their probability of getting a shot goes down. And it would have been okay, a difference of a month or two in getting an appointment would have been okay in other circumstances. But now we are in a scenario where we have a raging pandemic. There is significant, we continue, just to remind everyone, the mortality is lower, but it's not low. And so we are in that situation where every month counts. And so that's the concern some of us have, which is that I think it was very reasonable to have an age-based approach through 55, and it was obviously reasonable to add teachers to the mix. But beyond that, I think missing and not prioritizing people with comorbidities had implications.
We've asked the governor this, and he's been asked this many times since he switched to the strictly age-based vaccination distribution plan, and they've said this, it would be too complicated. It also in itself presents equity concerns if wealthier people have ability to get doctor's notes to prove their comorbidities versus communities with low-income residents. And so what was your reaction to that, Saad?
Well, that's what happens when you learn about the vaccine system on the job, not necessarily familiarize the senior cadres of your administration with the vaccine system, and have that kind of a superficial approach, unfortunately, to vaccine distribution, etc. I'll give you an example how it could have been done differently, and just to point out, since we are the state likes to emphasize the horse race numbers from the New York Times, etc., and other places, the same publications do not rate us really highly in terms of equity. So it's not that we are doing really well in terms of equity in our state of distribution, and so that this is an approach working. So I'll tell you, I had the privilege of being part of the first attempt at the national level to have an overall framework. That we were commissioned by the directors of NIH and the director of CDC as part of the National Academies of Sciences, Engineering, and Medicine. There was a committee created for this purpose that created the overall big picture framework. And that included people very familiar who have been working with the vaccine system for decades, leaders in public health and bioethics, etc. And they came up with an overall simpler framework, much simpler framework, but that threaded that needle back in late summer and early fall. And that framework was then used by CDC for their sort of more specific recommendations in several states, et cetera. And what happened was that a lot of states did not prepare for, and that framework, and then eventually CDC's framework, and even the drafts of the, where CDC was going, signaled throughout late summer and early fall that these groups were going to be a part of the priority groups, not precisely where. So although the national academies signaled where they will be, but they were considered, they were widely considered a high risk group. So what were we doing in terms of preparing throughout the fall for the system to equitably identify people with comorbidities? And one of the nuances that was out there was the fact that people with multiple comorbidities have a substantially higher risk, or certain kinds of comorbidities that are so severe that unfortunately they don't go undetected as much, had a higher risk in terms of death and severe disease, and should be prioritized, and states and jurisdictions should be ready to identify these groups. So not taking advantage of the time when these groups were prioritized, and not actually at least fully, there were draft documents from the states. There was a huge committee that was established, and so on and so forth. It is unclear that this drastic last minute change, how much input those groups had in the last minute change to an exclusive age-based group, age-based prioritization. But during the period, during fall and early this year, we had that window of opportunity to be ready for this. And other states are doing that. So it's not that we are so unique and our strategy has worked so well that we are doing so well in equity measures that this strategy was warranted. So I have a lot of respect for the sincere efforts and enormous efforts this state has put in to controlling this outbreak and ramping up vaccination. But the evidence, the recommendations from the CDC, from other expert groups, and groups that have had experience with setting up immunization systems, setting up eradication strategies, and so on and so forth, it doesn't compute well for our state to just say that it was just too hard, and therefore and using, unfortunately, equity as, I wouldn't call it a scapegoat, but because it's too strong a word, but equity is the reason why we couldn't identify people or prioritize people with not just comorbidities. So people's mild diabetes may go undetected, but unfortunately, people who are severely ill and therefore at a much higher risk, and just someone having a single comorbidity or a controlled comorbidity, just excluding everyone from that prioritization doesn't make sense.
I think those are excellent points that you raise. Saad Omer, again, he is the director of the Yale Institute for Global Health. Before we take a break, I just wanted to point to a Hartford Courant story just this morning, looking into what the state means by providing accelerated access to younger high-risk residents. And again, everyone being eligible over 16 on April 5th. Again, the state now leaning on healthcare providers to execute this strategy to find people more high risk so that they can get access to the vaccine. Is this problematic?
No, actually, that is part of the solution. But that part of the solution should have been there, and we should have been preparing for it throughout fall. As a country, we have been reacting to these kinds of things rather than being proactive. So I think that is part of the solution. All some of us are saying is that the change, and especially at the last moment, and if you remember, the systems were getting ready, people were getting ready for comorbidity-based prioritization after initial age-based prioritization, and this includes people in long-term care facilities and staff, and I don't think anybody has any concerns about prioritizing healthcare workers based on their risk and so on and so forth. But so doing so at the last moment caused a lot of consternation, caused a lot of confusion, and so on and so forth. So in working through providers and working with them, I think it's a reasonable strategy. But it could have been done and should have been done earlier, and it has been done in previous outbreaks as well.
You can join our conversation again as we talk about vaccines in our state, the strategy ahead. The number 888-720-9677, or find us on Facebook and Twitter at Where We Live. Coming up after the break, we're going to talk about vaccine passports. What questions do you have from them? You can ask our guests when we return. This is Where We Live on Connecticut Public Radio. I'm Lucy Nalpathanchel. Before the pandemic, most of us were used to traveling when and wherever we wanted. Now that coronavirus is here to stay, will countries, even private establishments, seek to control who visits them based on who's vaccinated against COVID-19? We're talking about vaccine passports now with my guests. On Zoom, Dr. Saad Omer, director of the Yale Institute for Global Health. And joining us now is Dr. Yara Asi, postdoctoral scholar in health management and informatics at the University of Central Florida. Yara, welcome to the show.
Good morning. Thanks for having me.
And our listeners can join as well, especially if you have questions about so-called vaccine passports. The number again, 888-720-9677, or find us on Facebook and Twitter at Where We Live. Yara, vaccination passports have been discussed long before the COVID vaccines were available. So walk us through what exactly is a vaccine passport.
Sure, absolutely. So it's actually a pretty straightforward concept. It's essentially would be some sort of digital or paper document called a vaccine passport or vaccine certification that in most instances shows that you've been vaccinated. However, there are some that would also be permitted if you've previously recovered from COVID or if you've taken a negative test within the last week or 3 days or something like that. And essentially, this would permit you to board airlines, cruise ships, and in some cases, we're seeing in the US, it's being piloted to enter sporting arenas, concert halls, maybe even indoor dining at some point.
I mentioned that people probably have been hearing about vaccine passports recently because we see more of our population being vaccinated. But you had said they're being used and piloted. There's something called Common Pass that's been available since last October, relies on a QR code that holds test and vaccination documentation. Also something, the IBM Digital Health Pass that you referenced, the Madison Square Garden in New York City was using, having patrons show this before they enter. And so I'm wondering if you can talk about, how this has been received in these areas that it's being used.
Well, I think it depends on the group that you're talking about. So obviously, if you are a part of the tourism industry, which is estimated to lose up to $1 trillion from COVID, you want to get things kind of moving as quickly as possible. So you're seeing a lot of the push for these kind of vaccine certifications from the airlines, from airline coalitions. In fact, a group of airlines recently wrote a letter to President Biden urging him to kind of move forward on this topic. However, as much as I want to get back to normal, just like everybody else, anytime you roll out a significant change or a significant social policy, we have to be mindful of the potential unintended consequences. And a vaccine passport program will only be as equitable as the vaccine distribution has been. And as you've been talking about, and I'm sure as your listeners have heard, we're not necessarily, both between countries and within countries, including the United States, we're not seeing equitable distribution of passports. We're seeing racial minorities, low-income populations are receiving vaccines much slower. There are dozens of countries that have barely received any vaccines at all and may not until 2022 or 2023. So then the fear is, if we open industry for a group of people who has the resources, who has the health literacy to get vaccinated early, are we creating a two-tiered system of freedoms based on people who either cannot or will choose not to get vaccinated?
You could join our conversation, 888. Again, 888-720-9677, or find us on Facebook and Twitter at Where We Live. Before we talk more about some of the advantages and the disadvantages of vaccine passports, Yara, I know some countries have been experimenting with this, including Israel. What has been seen there?
Yeah, so Israel has really taken a lot of headlines the past couple of months because their vaccination rollout has been extremely fast. I mean, outpacing their, competitors, primarily a lot of the Gulf states and other richer, smaller states by double or triple. I think at this point, they're upwards of 60%, and they've opened their vaccinations to a 16 and up, which many countries do not have the capacity to do. So kind of to both encourage young people to get the vaccine and again, to bring some life back to service and hospitality industries, they've introduced this Green Pass, which it's not fully rolled out yet, but at the moment, it would kind of allow you to move more freely within the country. So it's not necessarily for leaving and entering other countries, but if you can show that you've been vaccinated, you have more access to, let's say, a gym or another indoor place that you might have avoided beforehand.
When we think about the people who have yet to get access to the vaccine and how this can be problematic, I just wanted to hone in on this point. I've seen a stat: 1 in 4 nations won't get the vaccine this year. And that's not even on our radar here in this country as we fight over the distribution plan in our state, Yara.
Yeah, I mean, as Dr. Omar so eloquently put it in your first half, we should have really been planning to get the vaccine more equitably distributed globally and within countries, for many months before. I mean, we knew in April of 2020 that we would need vaccines to get out of this situation. And honestly, we got vaccines much quicker than I think many even public health people expected. So the fact that we are seeing so many countries that have not received vaccines. I mean, can't even vaccinate their high risk populations or elderly populations. And then we're talking about, well, what is a cruise line going to require? It kind of already is showing these disparities between, the global haves and the have nots that we've seen through public health crises throughout history. And my worry is that if we're able to kind of, quote unquote, return to normalcy for wealthier populations, high income countries, and the privileged populations in them, will the urgency to continue to vaccinate, to continue to social distance, to continue to mask, which the CDC still recommends even after vaccination, will that urgency continue if, for many people, for hundreds of millions of people living, in the global north, if life is essentially back to normal and you can potentially travel to a country where the local population is still in some form of lockdown? I think that really brings up some ethical problems.
I wanted to bring Dr. Saad Omer back into the conversation again. He's director of the Yale Institute for Global Health. You tweeted recently, Saad, that vaccine passports are likely to be implemented by private or government entities, whether we like it or not. So the question is to make them ethical, equitable, and effective. So how do we do that, Saad? I think, Saad, you've muted your mic, if you can hear me.
Sorry about that. There's a reason why unmute yourself was one of the most frequently uttered phrases of 2020, and I apologize for that.
No problem.
So I think I agree with what was said by Dr. Assi a little bit earlier in terms of potential ethical and even operational issues around these passports, or they will come under different names, etc. But the fact is, and the emerging reality is, there's so much incentive for governments and private entities, including businesses, etc., not just in hospitality, but all sorts of other businesses as well, travel industry and many other places where a large number of people gather, that we will start seeing these kinds of tools and instruments being used with some frequency. And the key is to make sure that they are implemented in a more ethical and equitable manner. And I'll give you an example. The big picture is that the most effective intervention against inequities is, against these kinds of inequities, is to make sure that the vaccine access is ensured, that vaccines are easily available. They're available to people who need it, not just in this country, but throughout the world. And I'd be happy to have a sort of a slightly separate discussion on what can be done, by this country and the rest of the world to make sure that low and middle income countries have access to vaccines. But focusing on, go ahead.
Yeah, we'll be talking about that soon, Saad, but go ahead.
Yeah, so in terms of, vaccine passports and these kinds of tools, so they, what we are likely to see in this country is specific businesses saying that, look, you cannot participate in our activities, or cruise lines saying that this is a vaccinated only cruise and that kind of stuff. And so I think implementing it too early may exacerbate some of these ethical issues. But there may be a point where the access is ensured and it becomes a matter of personal choice, not exclusively, but largely, where people are not getting vaccinated. So they are on a stronger ground in those situations to have these kinds of restrictions. But the other part of it is, what do you do? What is the penalty? What is the, what are the consequences of not having to produce that kind of a passport, as the vaccination rates go up? If the consequence is withdrawal of essential services, that's a different situation. That is more problematic. But if the consequence is that you can't go to to the opera or a concert or an indoor game or something where there are a lot of people in close proximity and that kind of stuff, that has a different set of issues, and perhaps the bar is lower in that context. But the big picture is to ensure vaccine access everywhere and do so quickly.
We asked our governor, Ned Lamont, this question about vaccine passports just the other day. This is what he shared.
The vaccination passports is interesting. I've had a fair number of conversations about that. Something we're going to look at, not now, because right now, not everybody's eligible for the vaccines. That would be fundamentally unfair. But within a month or two, when broad cross section of people are vaccinated, or at least have the opportunity to be vaccinated, I think local businesses, for starters, are going to probably take the lead on this.
And Yara and Saad, he went on to say he's had conversations with people in Connecticut's restaurant industry who suggested perhaps they could have something similar to the smoking and non-smoking sections of restaurants in days past for, say, vaccinated and unvaccinated patrons. Yara, what do you think about that?
I think that brings up a lot of questions for me. I mean, first off, we still want to ensure that as few people can spread or get infected by COVID as much as possible. So I would recommend to restaurants that, instead of having a non-vaccinated section, retain your outdoor dining. People, if you choose to require some sort of vaccine certification to eat indoors, that's one thing. But I think, it's very, very difficult when we look at any topic that segregates groups of Americans from each other, even if it's in a private business. And again, I completely empathize with restaurants and hotels and travel lines for wanting to get back to normal. But I really hope that there is an epidemiologist or a public health person helping make these decisions, because as much as industry, their job is to protect their industry, we still want to get out of this pandemic, sooner rather than later. We have these variants floating around. We have a lot of questions about the long-term, efficacy of some of the vaccines. There are many vaccines being offered that have different, efficacy rates. So I hope that we can balance our need to reopen business and get people back in restaurants and have, kids back in camps and whatnot with public health concerns, because the pandemic is not over, and it will not be over until a significant amount of the global population, not just in the US or in our town, is vaccinated.
You can join our conversation, 888-720-9677. Kathy from Simsbury. Kathy, go ahead.
Yes, good morning. There are several variants in Connecticut, as I understand it. I think there's probably 4 out of the 5. And Dr. Fauci testified last week in response to a question by Senator Rand Paul. Dr. Fauci was very clear about stating that the COVID vaccine protects against the COVID-19 and not the variants. My question is, what data is available to show whether and to what extent the COVID-19 vaccine protects against the variants?
Saad Omer, can you help Kathy with that?
That's a really good question. I'm really glad you asked that question, because it is indeed true that one of the major variants, which was initially identified in the UK, the so-called B117 variant, is a significant majority of our cases now. And that was to be expected based on the trajectory, based on the characteristics, etc. But just to clarify, the terminology, this is still a variant of COVID-19. So COVID-19 is the syndrome caused by the disease caused by SARS-CoV-2 virus, and that virus has different variants, and so it's not a different species. It's the same virus, but a different with some mutations and a cluster of mutations that make it a different variant. And so that's what the situation is in Connecticut right now, and in most parts of the country right now, that the B117, or many parts of the country, the B117 variant has taken over, or will be taking over in the near future, in where it isn't a predominant variant. There are other variants of concerns, etc., that I'll come to in a second. The good news is that based on the current data, the 3 vaccines that are being used, that are authorized for the US, seem to work well against this variant. The variant spreads more efficiently, it's more contagious, and there's some evidence that it is more dangerous as well in terms of causing a higher proportion of death and severe disease. But the good news, on the other hand, is that these our current vaccines are working against this variant. There are other variants where the data are a little bit more mixed, but seems to be the emerging picture is, so the variant, for example, that was initially identified in South Africa, the B135 variant, some of the data are a little bit more mixed, but the data are stronger for the vaccines we are using, even against that specific variant. And even for all of the vaccines, not just the ones that we are using, because if I'm sure your listeners know that there are multiple vaccines other than the 3 that we have authorized so far that are being used throughout the world. And so even for those vaccines, there is an emerging picture that suggests that even if they don't protect against the mild disease caused by these variants, there is more and substantially more protection against severe disease and death. And so while, as I was saying earlier on, that this is a cause for concern, but not to lose hope. We are keeping an eye out as an epidemiologist. I keep an eye on these trends, and so do all sorts of other folks in departments of public health and CDC, et cetera. So while these variants are being monitored, and what Dr. Fauci has been saying is that this works against COVID-19 causing virus that includes these variants. These vaccines work against those variants so far. In terms of the ones that are that are circulating. So what happens? Again, there's another question that is coming up. So what happens if a variant emerges where our current vaccines have less than optimal efficacy against? Well, the good news there is that we have other tools in our toolbox, and companies and research organizations are evaluating alternative options such as adding a booster, either for the same virus, the current version of the vaccine, or like the flu vaccine, a slightly different version targeting the specific variant. I don't think it's, we are at a point where we should make a policy or a clinical or public health decision to deploy any of these additional tools, but they are being developed in parallel so that we have more options. So it's a good question, some cause for concern, but so far the situation, at least in this country, is manageable in terms of the variants.
You're hearing Saad Omer again, director of the Yale Institute for Global Health. Also with us, Dr. Yara Asi, postdoctoral scholar in health management and informatics at the University of Central Florida. Coming up after the break, states in the U.S. are racing to vaccinate as many Americans as possible. But how is distribution playing out in other countries? And how should wealthy countries be helping make access more equitable? More after the break. This is Where We Live on Connecticut Public Radio. I'm Lucy Nalpathanchel. My guest today, Dr. Saad Omer, director of the Yale Institute for Global Health, and Dr. Yara Asi, postdoctoral scholar in the health management and informatics of the University of Central Florida. Yara, we're hearing this term vaccine nationalism. Can you talk a little bit about what we're seeing globally in terms of vaccine access?
Absolutely. So what we do know is there have been approximately 400 million doses of vaccines administered globally, which is fantastic. but only 10 countries are responsible for about 75% of those vaccines. So we are seeing a significant push in vaccinations, but it's primarily concentrated in highly developed and high-income countries. So the World Health Organization has a program to distribute vaccines to low-resource nations called COVAX. But even if COVAX goes well, and the rollout has been a little slow, it's only hoping to provide enough vaccinations for 20% of the populations in these countries. So the assumption is these countries will procure their own vaccines, they'll get some donations, perhaps as wealthier countries complete their vaccination programs, they will donate the surplus, and several countries have indicated that that's the case. Unfortunately, there's current estimates that up to 85 countries will not have any vaccination distribution rollout to a significant degree of their citizens until maybe 2023. So we have really prioritized, as you said, countries are engaging in this form of vaccine nationalism where they want to ensure that everyone in their country that wants a vaccine can get one first, and then they will decide what can go abroad and how they will deal with these underserved populations overseas. So it's only going to get exacerbated as we see vaccinations kind of heightening in middle to higher income states.
Assad, I wanted to hear your perspective and what role should wealthy countries like the United States play in this vaccine access?
I think we and the world will be paying the price of the U.S. staying out of the global collaboration to ensure access to vaccines worldwide for most of last year. So the COVAX facility that was mentioned, which is responsible for distributing vaccines to many countries, including most low and middle income countries, did not have a U.S. participation until very recently. And so what happened was when that agenda was being set, by our absence, it automatically became less ambitious, perhaps than, but realistic from their perspective, because the target is to vaccinate 20% of the population of these countries, of all countries, including low and middle income countries, by the end of 2021. And so the goal is unprecedented in its ambition, just to be sure, because it is a huge task, but it still falls short of a high enough vaccination rate target that will have a sustainable, that will achieve a sustainable control of that outbreak in those countries. So by our absence, the die has already been cast for a target which is not ambitious enough, unfortunately, to achieve sustainable control while being pretty substantive in its own right. So what we can do is to think big and bold, and not just in the context of donating additional vaccines, but being proactive in terms of technology transfer, being proactive that with that technology transfer, there is no restriction for low middle income countries to get those vaccines. For example, in India, there is a very robust vaccine manufacturing industry which usually has either has indigenous vaccines, but also through licensure. So the Serum Institute of India is manufacturing the Oxford vaccine, which is the backbone of this COVAX facility distribution at this point in many low and middle income countries. But there have been export restrictions placed on Serum Institute of India for exporting those doses. That means that even from a low middle income country, there are access issues, and it's not just vaccine nationalism of high income countries. So, but with the U.S. posture, which if it is forward-leaning, proactive, all of these bottlenecks can be eased up a little bit because it's in everyone's interest to get this outbreak under control everywhere.
Again, you're hearing Dr. Saad Omer, who is the director of the Yale Institute for Global Health, as we talk about global equity. Yara Ossi is also with us. Yara, when we think about the COVAX program not being well funded, we can all wait for countries to take a step towards that. But I'm wondering, just individually, when we see wealthy individuals, some of them stepping up. I was thinking of Be Like Dolly Parton, who invested in some of the vaccine research early on. And is that something that we also need to see, private citizens taking a stand?
Well, as beneficial as that is, I really hope that if there's any silver lining to this tragic pandemic, that we really learn lessons for how to do this next time. There will be another pandemic in the future, and we can't depend on the kindness of private citizens or even on the functioning of private industry. COVID could have been significantly worse. There could have been much higher mortality. It could have been much more contagious. It could have affected children much worse. It could have been waterborne. There are a lot of ways that COVID was much more manageable than some other pandemics that we've seen in history. So my hope is that governments and private industry and companies and airlines and everyone that's involved is learning, lessons from this that will help us really have a wider public global response. With a pandemic, you can't have 130 nationalized responses. You really have to have everyone working together. And this includes rich private citizens like Dolly and, also ministries of health in tiny low-income countries working together for the same goal. We all want life to go back to normal the way it was, January 2020. We can't depend on individual institutions of any size to do that alone.
Saad Omer, we just have 2 minutes. Did you want to give us some of your final thoughts on that?
Yeah, just to add to that, for some context, the 614 billionaires based in the U.S. Grew their net worth between March and December 2020 by approximately $930 billion. And the current shortfall in the COVAX funding is $2 billion approximately. And this includes the new funding the Biden administration has provided of $2 billion now and $2 billion later. I absolutely agree. Sustainable efforts to control outbreaks and prevent the impacts of pandemics require combined global actions, not individual reliance on individual generosity. But this is the context in which we are living in a highly inequitable world, and resources and leadership in this area of vaccine distribution throughout the world is urgently needed.
Well, this has been a really interesting hour. Thank you so much, Saad Omer, director of the Yale Institute for Global Health. We appreciate your time today. Also, Dr. Yara Ossi, postdoctoral scholar in the Health Management and Informatics Department at the University of Central Florida. Today's show was produced by Carmen Baskoff. Our technical producer is Kat Pastor. We're back tomorrow. I'm Lucy Nalpathanchel.